Okay, guys, we're going to go ahead and go through communication or PowerPoint. You guys will follow along and take your notes as we do this. Let's go ahead and start. So communication covers a lot of different things. It's not just simply, talking with the patient. It's about how you're going to control things, how you're going to manage the communication needs to be done. You're talking to patients, you're talking to other healthcare professionals, you're talking to allied staff, which is hospital staff. You're talking to law enforcement, the bystanders, the patient, the family. There's a lot of different people we're discussing things with here or talking with, and all of our communication is important here. Accurate and effective communication. Some of the things we need to look at here. Noise is definitely one of those things that we need to limit. In situations I come into a home, I've got radios playing, I've got TVs on. I may just simply turn them off because noise can be a problem. Other family members around that are talking loudly or interfering with communication, we need to move them out of the way. Lighting is definitely important because the patient needs to see us and we need to see them. They need to be fully aware of what's actually going on as well as we do. Privacy, patient level. The privacy of the patient is important. We want to keep that personal privacy. And remember, we talked about this in class. Even somebody underage, there still is a fine line of privacy we have to provide you, even from your parents. Um, that is a fine line. Please know that there are certain things that we're going to have to bend those rules a bit. But there's certain things we can kind of keep private, and we have to try and do that. It's patient information, privacy. Patient's level, this is their level of response. Are you oriented times 1, 2, 3, or 4? The basic 4 questions: who are you, where are you, what day is it, what time is it, or who's the president? Um, and then the AVPU as well: alert, verbal, painful, unresponsive. So if you're alert, we ask the 4 questions. If you're painful, verbal, painful, or unresponsive, obviously we can't ask the 4 questions. Personal space. We have to abide by personal space. You can see these two EMTs are doing their job well. They've invaded the personal space. If this patient is conscious, though, they're going to be informative. They're going to tell the patient what they're doing so that the patient actually is aware. And we're going to invade that personal space because we have to. There's reasons why. Minimize interruptions. Again, we got family nearby, we've got the noises going on. All these different things can become interruptions. Even the phone and all that kind of stuff. People are calling when they recognize that you've called 911. Someone's at your house. They're now making phone calls. So we need to do what's necessary to try and minimize those interruptions. And when we're dealing with the patient, talking directly to the patient, same thing, minimizing that interruption. There, we ask a question to give us information. We don't let them go off on tangents and spend a long time explaining things. We want to kind of get it concise and finish it off right. Um, Active listening. This is a very simple thing to do, guys. Active listening requires you to make eye contact, to nod your head in agreement or at least in understanding, to reiterate back to them with their answers. So when you ask a question, they say, yes, it's a 10 on a 10 scale. You say, okay, so you're telling me it's a 10. That's telling them that you're listening, you're hearing it, both for you and for them. Um, Barriers to communication. You can see this mask going on right here. This will be a barrier to our communication because if she tries to speak to us through that mask, it's going to be muffled. We need to listen a little differently, a little more intently. Um, Other barriers are, again, our surroundings and noises around us that become that barrier to that communication. TV on, other people talking, phones ringing, cell phones ringing, that kind of stuff can be barriers to communication. Procedures that we need to follow are, what we have in place, what the next steps are going to be as far as treatment of the patient is concerned. And so we need to let the patient know. This is where we let the patient know what we're going to be doing, procedures wise. What's the next step? And then finally, body language, guys. 90% of your body language is read by a patient and tells them exactly what you're thinking and how you're feeling. So you need to watch your body language. Be careful about how you present yourself. Um, Body language is a huge, huge portion of our communication, and we can let a patient know exactly how they're doing based off of our overall um, presence and how we appear to them. Um, at the same time, we can also show them disdain or lack of interest when we turn our backs, when we cross our arms, when we don't become good active listeners. These are things that kind of put the patient off to where they stop talking to us, to stop giving us information because they feel like, well, you're not even here to talk with me. So body language has a lot to do with this. And we're going to talk more about this. Definitely something I want to discuss with you guys. We've discussed this already. Open-ended questions. Please tell me what made you call an ambulance today. So an open-ended question gives them the opportunity to give you an explanation in their own words. Sometimes we can't get a full answer and we need to close that down. And by closing it down, you have an answer like this or a question like this. Okay, you have told me about your chest pain. Do you feel pain anywhere else? It's a simple yes or no question. It's narrowing it down. So we want open-ended questions first. The closed-ended questions, what we lean to when a person can't give me the proper information. Finally, we have pitfalls, and pitfalls are just that. If I go in constantly in a closed questioning type situation where I'm feeding them information, feeding them answers, and they're regurgitating those answers back to me, am I getting the right information about what the patient's feeling? It's the same thing as chest pain. So you're telling me you have a chest pain. Does it feel like it's pressure? By asking them, does it feel like it's pressure? The person who doesn't know how it feels is going to turn around and tell you, yep, it's pressure. We want them to think about it. We want them to give us their honest answer and what they think it feels like. So the pitfall here is not using the open-ended question, consistently using the closed-ended and really closing it down too far that nobody has the ability to choose. So you want to give them the choice. Guys, I don't know what the heck that is. Moving on next. Communication patient to other providers. So again, we're talking about communication is not just with the patient. This is with other providers as well as the hospital staff, the ambulance crews, the fire department, and law enforcement as well. Radio communication, portable radios, mobile radios, and base station radios. What we have here is this is your portable radio. This is what you find inside the ambulance, which is connected to a repeater station that's up high in the mountains. We have some behind us in the Lava Heights. That radio signal sent to those repeaters and then back down to our dispatch center for an ambulance crew. And so this is how we have our basic communication between us and dispatch and us and other units. Then we have the mobile radio, which is right here. Okay. The mobile radio allows us to actually move around and walk around with the radios, get outside the ambulance and do that kind of stuff. And then base station radios as well. Base station is the hospital itself. They have their own radio systems that we communicate directly to them through other channels, giving patient information and letting them know what we have going on. General rule when you're talking on radios, and this is one of those things, if you've never done this before and you get an opportunity to try it, because it definitely is, it's a little different than you think. It's not as simple as you think. I mean, I remember when I was a kid playing with walkie-talkies, we just play around and have a good time. But reality is using radios correctly is kind of a challenge. So general rule here is speak slowly and clearly, hold microphone 4 inches away from your mouth, only speak when necessary, listen before transmitting, do not use names or transmit confidential information. We can't share the person's name or anything that's confidential that we could be in trouble for. This is a HIPAA violation kind of thing. Speak professionally always. Ensure your batteries are charged and follow local procedures and protocols. So when we're talking, our local, our ambulance company has ways in which we communicate with each other. They're pretty much all the same, but there's some varying differences inside that procedures. So we want to follow those procedures for our individual companies. Challenged patients. In some situations, we're going to come across these patients. They're a little bit challenging to deal with. We want to take our time. Let's talk about, say, it's a 5150, a psych patient. And that's in this case, in some cases, we're going to want to take our time. We're going to go slow. Most calls run about an hour. You get a decent psych patient, it's probably going to take you 2 hours plus because you've got to convince them. You've got to talk with them. You've got to gather information. It's a lot of work. Ask the family how to communicate with the patient. Always make sure you ask them about what's the best way to communicate. Maybe this person is actually deaf and does sign language, and you have your partner, sign language, or you can find someone to do that. Maybe they don't speak English, and that's kind of where we're having the problems. So we need to find an interpreter. And outside of that, maybe they just have problems hearing, and the family can help us with that. Do not assume reduced intelligence. We never want to assume that someone is slow or unintelligent. They are intelligent, and we need to make sure we treat them as a grown adult, or as not a grown adult, excuse me, as an intelligent person, asking appropriate questions and listing the proper response. Do not shout. Even if the person is hard of hearing, we're really not shouting at the person. Okay, you're gonna talk louder, but don't yell and don't shout at them, because it even a person who can't hear, has trouble hearing. That's gonna put them off very fast. Raise your voice, be stronger, maybe closer to the patient, and try and get that information to them. Here's an issue right now. Just think about this. A lot of communication is done through, as we speak. A lot of people are looking at lips, right? They're watching your lips move. And so now with COVID, we have this issue with wearing masks. I got to get close and talk to somebody, but they have a mask on. How am I supposed to communicate with them if they've got a mask on, right? If they're reading lips. So here are some of the challenges we have to work our way through. So deafness, blindness, mental impairedness, differentiating between AMS and normal status. So we are going to come across people that are deaf. Here's a gentleman here. If you're not sure about it, you can see right behind he's got a hearing aid. These are getting smaller and smaller and harder to see sometimes. So it's something that clues us into definitely need to make sure he understands what we're saying. Blind patients, they don't have any problem hearing you, but you're going to have to be explanatory about everything you're doing, because they can't see it. They can't see it happening, and you need to explain everything you have going on. Mental impaired, altered mental status, or psych patients, people that aren't capable of really understanding what's going on, or have these moments of clarity and then they go back into this confusion state. We have to think about that and take our time, go through that carefully. Differentiating between altered mental status and normal status. If you have a patient that is confused and doesn't really understand what's going on, that does not necessarily mean they have a a brain issue. They're altered in the typical medical sense. They could be Alzheimer's, okay, and the patient could be simply confused. Organic brain syndrome, brain cancer. These are things that could lead to their altered mental status. So we find it, we identify it, it's a concern, talk to family, talk to bystanders, friends. Is there a reason why they are this way? Is this normal for them? And if it's normal, we chart it and we understand that it is normal. All right, so we're going to go ahead and stop there. You guys should have taken care of the notes, and there should be a couple of questions for you guys to answer as well. Thank you for your time. Good work, guys.